Good afternoon, everyone. Thank you so much for coming. My name is Lindsay Oliver, and I am the marketing coordinator for Snoqualmie Valley Hospital District. And I would like to present our guest speaker today. Dr. Kim Witkop is our Vice President of Medical Affairs for the hospital district, and she will be speaking to us about hospitalization and acute care. So please welcome Dr. Kim Witkop.
Thank you. I get to get myself all situated. I've recently gotten to play the patient role, so while I'm in my recovery, I see many things here that I'm glad I didn't have to take advantage of, but glad I knew the information if I needed to. So let me get everything going up here. So I've titled this Seasons of Care, and if we think about it in regard to healthcare and the healthcare environments that we enter, that we come in and out of, there really are three representative areas. So the steady state area, and so that's where I'm going to declare that all of us are today, that we are all living our day-to-day life in a relative level of healthiness, at least a level of healthiness that allows you to come to events such as this, go home tonight, to your own home, go and do your grocery shopping, things such as that. Then the other two steps along this circle are the hospitalization, which is where we're going to spend our time today. And then there's this transition time that is the post-hospitalization. And so my hope is that no person finds themselves going around and around in this circle. But anyone who does need to engage in the hospitalization is very likely going to need to transition through that post-hospital phase in order to return to their steady state. As I constructed this slide, I probably should have made the steady state word much larger so that it didn't feel like that these were all equal times, equal seasons as we're contributing, as we're involved in the healthcare system. So we're going to focus just on the hospitalization component. So I've got two computers going on here at once, so forgive me if I do one and not the other. So we're just going to focus on the hospitalization component, and in December, we're going to be talking about the post-hospitalization or the post-acute care. So as we look just at the hospitalization component, there are several access points for hospitalization. One of them is going to be through the emergency department. That's probably where most people think about. They had an acute illness, they had an acute injury, they went through the emergency room, and from there they found themselves admitted to the emergency department. And their arrival in the emergency department can be either by ambulance or by car. Now what many people think, or they haven't stopped to think about it, and they presume that just because they go to the hospital in an ambulance means that there is an admission that occurs. And that actually is not the case. Only a small portion of the people who arrive in an emergency department in an ambulance actually find themselves admitted to the hospital. You can also come to your hospitalization by way of another hospital. Maybe that hospital was unable to meet your needs. You had a preference to go to a different hospital. Your insurance demanded that you have your hospitalization at a different hospital, where the specialty care that is provided at one hospital is more suited to the needs that you have at the moment. So there is very common transition of a patient from one hospital to another, usually from an emergency department to the other hospital. A physician's office can also be an access point. You went there for whatever was currently the symptoms going on, and that prompted a hospitalization. And then a hospital outpatient department, maybe outpatient surgery, that at the end of the hospitalization you just weren't quite ready to go home, or they discovered something in the course of the hospitalization, or excuse me, the course of the outpatient surgery that now prompts a hospitalization. This isn't an exhaustive list, it just represents the more common. So when we talk about hospitalization, and we're going to define hospitalization as occupying a bed in a hospital. I know that's simplistic, but that's really how we're going to characterize it. You're going to occupy a bed in the hospital, and you're going to do that overnight. There are two varieties of ways that you would be hospitalized. One is in a status called observation, and the other is a status called an acute admission. And the purpose of observation, and we'll spend a bit of time on that, is the scenario where we think you need to be admitted. It feels like you need to be admitted. We're concerned that things are going to get worse and you're really going to need to be admitted, any of those. But you haven't yet met what's called admission criteria. So now I'm going to introduce what's going to be a lot of our conversation for the rest of these 40 to 50 minutes. And that is, so many of the things that happen in the course of a hospitalization have to do or are a reflection of regulation that is around this industry called medical care. So either the insurance companies have some regulatory authority or some things that they impose on us as we're providing care, or federal agencies or state agencies. So we'll be reflecting on that as we go through, and you can see how that is all shaped. But one of these issues, catch me if I fall, one of these issues is what's called admission criteria. And so there is a large book, several inches thick book that lists things that have to be present in order to justify a hospitalization or an acute admission. And if those aren't present, then there will be no payment provided for the admission. And that is one of the reasons for this observation status, is insurance carriers, and that includes Medicare and Medicaid, they will cover an observation stay when it's for the purpose of identifying if there is something in the works. Is there something brewing, something that's going to disclose itself, and in that time, then the criteria are met and a hospitalization or acute admission can occur. There is still care going on during the observation time. There's still evaluation going on in the observation time. It really has a lot more to do with the payment and how the payment is structured. And as healthcare providers, when somebody's in observation status, we are constantly asking ourselves the question, have I learned something that now prompts me to go ahead and move this person into an acute admission? Or have I learned something that says hospitalization actually isn't necessary, they can return to home? So now the admission for acute care. And that is, the scenario is when the condition can only be cared for in a hospital setting. That is the criteria that you're looking for to justify an admission. So yes, there's a big book, and the big book that we look at, that's the admission criteria, but that's the common theme in that big book, is something going on that the care to address this problem can only be dealt with in a hospital setting. And rapid recovery is not anticipated is the other key part, because again, that's what observation is for. I will give you an example. Somebody comes in with a kidney stone. They're in excruciating pain. They need medications that can only be administered by IV route. And so clearly they need to be at a hospital level, but we also see that that kidney stone is almost done. It's almost passed. And so that person would be managed under an observation stay, because it's expected to be a short term that they require the services that are provided at a hospital. And then they would be discharged to home, because once that kidney stone passes, you no longer need to be in the hospital setting. So that's the scenario around why rapid recovery is not anticipated. That would justify an admission. So when we talk about acute care, and I've kept using this word for you, but I haven't defined it. And so acute does not refer to the duration of care, even though we just said duration of care has some impact on observation stay. It does not mean that you're going to have a short stay. It says that it's the intensity of care that you're going to be receiving, and an acute level of care only occurs in a hospital environment. Acute also applies to all the different aspects of a hospital. It's not just the medical care environment. It's the intensive care unit, it's labor and delivery, it's your surgical areas. They all fall under the acute admission. So in this scenario, you are coming into the hospital, and this is the first time, and you are wondering, why are we going through all the things that we're going through? I'm sick, I'm hurting, I'm miserable. It kind of encompasses it all. Yet there's all these things that have to happen. And this is the impact of being in an environment where there is regulation placed in our world. And I'm not saying that that's bad. There's a lot of very good things that come out of that regulation, but that's part of why this is a little bit of an endurance course to actually get into the hospital. So my hope is that by giving some insight, it will make it more tolerable, if hopefully not you, but if you're ever accompanying someone else who has to go through the admission process to a hospital. So there is paperwork. And these days, we're working rapidly on moving things from paperwork to electronic format or a digital format, but it is paperwork nonetheless. Items that have to be signed, that we have to receive your consent for care. We have to be given consent to bill your insurance carrier. And then we also have to make sure that both parties understand that there is privacy involved here. These are usually all put into one document, but these are the three elements that are within that one document. We are also obligated. This is a Medicare requirement, and things that are Medicare requirements we tend to just apply to everyone as opposed to doing different processes for different insurance carriers. Medicare requires that we ask if you have a living will status. That answer can be no. We're just obligated to ask and document what the answer is. Yes, don't want one. No, I've never thought about it before. It doesn't matter. We just need to document what that is. There are also certain demographics that we are obligated to ask. We must document race, ethnicity, date of birth, and primary language spoken. And again, this is a requirement that comes out of the federal government. And so it can, for some people, feel like it's somewhat of an invasion or an offensive question, but it is simply a collection of information that we need to get, and then it is utilized. It is utilized in bulk or in group format as they do statistics across the country. There's also some good reason for it too. If you look about the primary language, we would certainly want to know if the language that they understand was something other than English, which is our primary language spoken in our local hospitals. We would sure want to make sure that we were able to give patient education in a language that spoke to the heart of our patient. And so you can certainly find application for each of those. In order to be admitted to the hospital, you must have orders. Those orders must come from a physician. In our current systems, a mid-level, that's a nurse practitioner or physician assistant, cannot provide orders to be admitted to a hospital. Again, this is a Medicare regulation. Only a physician can do it. There's also protocols that can piggyback onto those physician orders. For example, there's chest pain protocols. If you arrive in the emergency department with chest pain, there are things that will be done immediately, not waiting for a physician to come in and give orders. Physicians have given those orders ahead of time, saying, if any patient arrives with, then do this. And that's done in a group setting as a medical staff. We give those orders ahead of time. Every patient will have a history and physical exam when they're being admitted to the hospital. And I wish I could say everyone would have a history and physical exam, but what you will have is that history and physical process will be done by every discipline that interacts with you. So while, if in this scenario, I'm the admitting physician, and so I have taken a history from you, the patient, and your family, and I've done a thorough physical exam and generated my orders, whenever a rehab therapist comes into the room, they're going to have looked at what I wrote, but they also have an obligation to gather history of their own. We're each going to be asking questions from different perspectives as well. That's part of the group or the team mentality of approach to medical care. And we're each going to need to do our own exam from our own perspective as well. So while it feels like, wasn't this just done? Weren't these questions just asked? In fact, they were, but the obligation is to do it, and it is in your best interest for us to do it in that way. We've just made it through the first few hours of your hospitalization to get through that part. But one thing I really want to sear into your head are the expectations that any patient should have as they come into a hospital. They should have the expectations of understanding what all the staff roles are. of those that are caring for them. There are a multitude of faces that you as the patient will interact with in the course of the hospitalization, and recognizing what those roles are. We'll spend some time with each of these. You also have the expectation that you will experience safety in your environment. You will also experience safety in the medical care that is given to you, and you will also will be respect for your autonomy. Autonomy means your decisions, your preferences are honored above all else. And so we're going to spend time going through each of those. I've already given some insight about the regulatory oversight that occurs in healthcare. This is a very short list, actually. So I know some of our staff are in the room, and they could probably each right now in their head come up with at least 5 or 6 more that I could put on this list of the different regulatory bodies that come in and provide requirements, regulations, oversight for things that we do in the realm of patient safety or community safety. So again, this is not all bad. It just means we have to work within this environment. So talking about the staff roles, and I'm just limiting this conversation to the clinical people that are providing care. You can imagine the multiple non-clinical care, non-clinical staff members that are involved in the process as well, from housekeepers, all the facility staff members, the registration clerks, on and on. So the clinical staff members, the obvious being the nurse. Again, remember, you're being admitted because this is care that can only be provided in a hospital setting. That really means you're being admitted for the nursing care. That's where the nurses reside. The nurses have nursing assistants. There's often referred to, as CNAs, certified nursing assistants. Respiratory therapists, rehab assistants, and they have 4 different disciplines that reside within the rehab department of physical therapy, occupational therapy, speech therapy, and recreational therapy. So the emergency room has nurses, has doctors, has emergency room technicians in it. Then you also have all of the ancillary staff. So that's your imaging staff members, your laboratory technologists, dietitians, social work, pharmacists, physicians, the physician assistants, and the nurse practitioners that we already talked about. So you can see how this list gets long, and I see so often, and for any of you who have either been hospitalized yourself or been the family member of somebody being hospitalized, becomes very confusing. You are suddenly thrust in an environment where you don't know all these processes. Why is this happening? Why did I have to fill out that piece of paper? Who are you? You're asking me to do what? And so as medical staff members, being really sympathetic to this huge community that an ill patient or an injured person has been thrust in the middle of. It's one thing when you've done it before, and so it has some familiarity to you. But when it's your first time around, this is overwhelming, and most patients see at least 2/3 of representatives from these different disciplines. So again, that's back to a sympathy perspective. I said that you should always be able to expect safety in your environment. So that means protection from infections. And so we use isolation a lot as a way of, it's quarantining, trying to keep infections from occurring. This is usually a patient who has an infection that we don't want to be transmitted to others. We will tend to keep them in an isolated environment, and that is really not for their protection, it's for the protection of everyone else. So the other patients that are also in the hospital at that time, we don't want to be transmitting from the person in room 1 to the person in room 2. And so we will use all varieties that we have at our disposal to try and keep the infection from transmitting. So we will use gloves, we'll use barrier gowns. You'd never allow anything to transition from an isolation room into any other room. Things stay in. There's a cleaning process that things go through as they come out of those rooms. When those rooms are cleared, I mean, when that patient either no longer requires isolation or is discharged, that room goes through a different level of cleaning process than would be a standard room cleaning. So we also, around food, obviously if you're going to be in the hospital for a little while, you're going to want to eat. So we're always going to be attentive to food allergies. And I put the word correct diet in here because your expectation should be that you will receive the correct diet. And that's not always welcome, meaning if you've been admitted to the hospital because you have a complication from your diabetes, you have a complication from your heart disease, we're going to give you a diet that is constructed for someone with diabetes. We're going to give you a diet that is constructed for someone who has underlying heart disease. We're not going to continue to contribute to what got you into the hospital in the first place. And that's the part that's not always welcome. We have to remind folks that we are obligated to do the right thing, despite the fact that somebody with diabetes would really like their ice cream tonight. We'll work on finding an alternative sweet, but back to correct diet should be your expectation. We, both our hospital and all hospitals, use all standard, as a standard safety needle, meaning we don't recap needles, and that's for our safety as well as anybody around us. So needle stick injuries are so far fewer than they've been in years past. There's also, we talked about isolation as a mechanism of preventing for hospital-acquired infections, but there are other ways that we do this too. There is constant and continual hand washing occurring. So before and after every patient contact, our staff members will be cleansing their hands, either hand washing at a sink or using an alcohol-based cleansing product. We do mandatory flu prevention. Our hospital has done it for several years, and most hospitals in the state now do mandatory flu prevention, meaning we have committed that patients will not acquire the influenza from our facility. And so all of our staff will commit to a flu prevention program, either by receiving the flu immunization, or they will always be masked when they're in a public environment within our hospital. Our facility for the last 3 years has been in complete compliance with this. More and more hospitals in the Washington State area are coming into full compliance with this as well. And then catheter management is another. We know catheters are a great source of infection. So those are both catheters that go into the bladder, as well as catheters that go into the veins for us to administer medications through. Those are great source of infection, and so we have management programs specifically with the intention of preventing infections from occurring. Latex is an increasing allergen out there, and so we have a latex-free environment. So you'll see hospitals no longer allowing the latex blow-up balloons. You can only use the Mylar balloons in because of the latex. All of the products that we buy are latex-free. The paint that we put on the wall is either latex-free or minimal latex. There's some scenarios where we can't completely avoid, but then there's no contact with that paint for many hours, many days, in fact. And then we also manage visiting hours. That's a safety element that you should expect, that we will have quiet times. We will have quiet times for patients to rest. We will have quiet times for staff members to be able to concentrate and be free from distractions, from errors and such. Oh, I'm sorry. The other thing is safety just in your medical care. The slide before we were talking about safety in your environment, and now we're going to talk about just safety in your medical care. The assessments that we already talked about, the history and physicals that's done, those assessments will continue on throughout the course of the stay so that any changes in your condition can be identified. There's also what's called the 5 rights of medication administration. Medication errors have historically been a huge issue. Patients getting the wrong medication, getting the wrong dose, the wrong timing, what have you. So this 5 rights is, again, what you should expect to occur. It should be your meds. It should be coming in the correct route, oral, IV, other. It should be the correct dosage that you get there. It should be the correct time of day. And obviously the right medication should be chosen. The technology is greatly assisting in this realm, in that now what occurs, at least in our facility, is every patient has an armband. That's always the case, but on that armband is a barcode. All of our medication also has a barcode on it, and the the medication administration record, which is the guideline that says this patient is due for this medication, is in a computer. And so through bar scanning, we barcode the patient's label, we barcode the medication, and then look for the computer to say to us, in fact, you've matched everything up correctly. Proceed now with the administration. So because of that, we're seeing medication errors across the country for facilities that have implemented a system like this drastically falling off, and that's so fantastic. As we just keep going on, so we don't get held up on any one point, your expectation should be accuracy. So your laboratory result of whatever that is, that's the right answer. It is an accurate result. We use all kinds of quality controls. We have standards that are applied in that realm. And we also do privacy protection. Remember, at the admission process, we signed a document with you that said we both enter this contract that says we will protect your personal health information. And this continues on to say, we will protect your privacy. We're not going to divulge information about you outside of sharing it with those who are involved in your care. You can also expect bodily privacy, so privacy in both regards. Curtains will be closed, doors will be closed, conversations will be kept appropriate where you aren't finding yourself embarrassed and such. And then falls, we prevent falls. We're going to talk just a little bit more about autonomy. Remember, I said autonomy is where the patient's preference comes above all other things. So we don't restrain. The restraints are highly discouraged. There's only a few times, I mean, we can all probably remember stories of your 60s and 1960s and 70s where there was a lot of restraints going on for patients who were acting out, resistant, really weren't in their right mind. That doesn't happen these days. I mean, there is a time and place that it's appropriate, but you just don't see restraints occurring now. But because we also honor the patient's autonomy, the patient's insistence on getting up, the patient's intentions of moving about, we have to accept that we may not be able to prevent all falls, but what we can do is prevent injuries that occur from the falls. And so as you tour through hospitals, you will see patients who have a gait belt on, and that's simply to allow us an opportunity. If they fall, we can easily grab them and help either prevent the fall or help them in a lowering to the ground in an effort to prevent injuries from the falls. So the respect for autonomy, I think this really deserves some of our time, and that is around all aspects of care. But the time where autonomy really comes about into play is end-of-life preferences. So that's where the living will. Remember, at the time of admission, we ask you, do you have a living will? We want insight into what your thoughts are in regard to end-of-life issues. And if a patient says, my preference is resuscitation, my preference is not to be resuscitated, my preference is to receive dialysis therapy, my preference is not, then as long as we feel like that we are receiving information from a competent person, that's the answer. That doesn't mean we won't educate and converse, but the patient's answer is always the answer. And that also includes donor status. If someone says, I am an organ donor, I desire to be, then we will honor that preference if this hospitalization happens to be the time of their death. And then DPOA stands for Durable Power of Attorney, which says it's a surrogate that you as a patient have nominated someone else to speak when you aren't able to speak any longer. So again, that falls under autonomy, because if you've asked someone who isn't a family member to be your durable power of attorney, then we're going to respect your wishes, and that's who we're going to turn to for answers when you can't speak for yourself anymore. We will honor your autonomy despite the fact that you have other family members who would like to speak into the decisions. You have said when you were competent and you were able to speak, this is who you want making decisions for you. That is who we will turn to. Also, of autonomy is participation in care, participation in all decisions, being communicated to, receiving education. That's part of being a participant in your own health care. And this also includes refusal of care. So if someone were to say, I choose not to receive care, and it doesn't matter what their reasons is, maybe it's because of religious preference, maybe it's because they value independence so much they don't want to proceed forward because this conversation feels like it's going down a road of becoming more dependent. There are all kinds of scenarios out there, but refusal of care is just as important as accepting care. And again, it all falls under patient autonomy, which again has the highest preference and is honored the most. The experience of the rest of the hospital stay is really going to be dependent on what was the reason you were admitted in the hospital in the first place. So if you were admitted because you have some incredible orthopedic fracture, there's going to be a lot of pain with that. That's going to color your experience. If you're here for the delivery of your baby, that's going to be an entirely different experience. So again, what actually is what you would characterize your stay to be is so reflective of what got you there. So we won't be able to say much more about that. The expectations, though, we said you're going to have continuous assessments. That means vital signs and it's going to be monitored even throughout the nighttime, so there'll be disruptions in sleep. And because we need data, there'll often be laboratory tests, x-ray tests, because we need those to make decisions for your care in the course of the day. Those often happen in the morning. So the sum total, and we also get you up out of bed because we don't want blood clots. So kind of the sum total of this slide is the hospital is a horrible hotel. It is not a place to get good rest, but it is a place to get well. So you finally got through it, and now it's time for your discharge. So you finally are to the place where you no longer require being in the hospital to receive the treatment that you need at this moment. So now your destination options are home, going to skilled care, or going to long-term care. So there are more options beneath each of those, but this really are the three big areas at the time of the discharge where you, or the patient you, will be heading next. So the decision for discharge is when the patient's considered eligible for discharge when they don't need to be in the hospital setting anymore. This doesn't equate to a readiness to go back and doing things on your own. And I think that's an important thing that for me to share with you is so often patients will say, you say I'm ready, but I say I'm not. I can't go up and down the stairs. I can't make a meal for myself. So no, you're not ready to go home. You also don't need to stay in the hospital environment anymore. And that is what's called post-acute care. And that'll actually be the conversation that we have in December, is what all is included in this post-acute care conversation. Really the highest priority in making these decisions around the time of discharge have to do with patient safety. Autonomy, again, always trumps. But in those conversations, it is really about what is the safest environment for you to go to next. So that is what we will be talking about in December. Lindsay, how much time do I have that I can open up for questions? 10 minutes? All right. Thank you for letting me just forge ahead and speak. But any questions, I'm happy to go back and answer anything. So the question was, is there a way to go ahead and kind of prep your admission, going ahead and filling out a lot of the information ahead of time so that that's one less thing that has to occur at the time of the admission process? Absolutely. In fact, we encourage that as much as we can. And once you've been admitted into a healthcare system, your information now is embedded in that system. So we definitely encourage that as we go into health fair environments, going out into senior centers and such. That's exactly what we encourage to be done, and something we want to do even more of. Yes, definitely. So as we come back, and I'll hand it back over to Lindsay in just a second, but as we come back in December, again, we'll talk about a post-acute care, and that's really going to be those decisions about home, what kind of support and support services can we bring into the home, Is it going into a post-acute care environment where it's more of a transition? So that would be a skilled nursing facility, and there's a variety of those. Or is it going into a long-term care environment, which is always a really hard decision to make, but sometimes it's the right decision to make. So that's the ground that we'll be covering then in December.